Good afternoon, and welcome to Wayside's Recoveries Center's Maternal and Infant Health Series. Today, we will be hearing about emphatic communication strategies and exceptional grief care after reproductive loss. We have Kathryn Grauerholz, and we also have Dr. Lauren Rubal. I was going to spend time to share a little bit about Wayside Recoveries infant and maternal health series. Recently in our annual report, they just shared some of the highlights of the work that we have been doing, and it is contributory to many of you who are attending today. Many of you have attended many sessions, have completed surveys, and given us very valuable feedback. And so we know that in 2021, Wayside launched this free educational series in partnership with Minnesota Department of Human Services as a SOAR 2 grant with SAMHSA. And we focused on fostering collaboration between patients, community providers, and health practitioners to deliver high quality care to birthing people, infants, and their families. This virtual series kicked off in June of 2021 with Dr. Kamara Jones, the former president of the American Public Health Association and past medical officer of the Centers for Disease Control and Prevention, presenting on the impacts of racism on health and the well-being as a public health crisis. I would just like to share with you, in our first year, the series has engaged a national audience reaching more than 1,000 community members, including 522 clinicians and over 93 hospitals, clinics, and universities. I just would like to say thank you again to the presenters for their time today and the valuable information that they're sharing, because doing this work together helps to increase all of our network and resources and providing care and really hoping to reduce the disparities in outcomes for birthing people. So thank you. And without further ado, I would like to introduce you to our presenters. Lauren Rubal is a USC-trained reproductive endocrinology and infertility physician with a boutique practice in Orange County, California. Her unique approach focuses on fertility, recurrent miscarriage, and painful or abnormal cycles using an integrative lens. Dr. Rubal is a fellow in integrative medicine at the Andrew Weil Center at the University of Arizona and a FEM fellow at the Reproductive Health Research Institute and the Leon Fellow. Dr. Rubal's greatest career achievement is one defined by its end, leaving a traditional REI partnership to pursue a radically reimagined vision of reproductive care. Her mission is to identify the root cause and heal reproductive issues in a restorative manner. As such, she walks alongside many patients who have experienced reproductive loss. She focuses on holistic methods to help heal from this and has presented nationally on this topic. Also, I would like to share Karen Grauerholz is an adult nurse practitioner and an advanced certified hospice and palliative care nurse. She has earned her undergraduate degree in nursing from San Diego State University and a graduate degree in nursing from the University of San Diego, and has over 2 decades of experience working with adult patients in preventative medicine, weight management, hospice, antenatal, distress counseling, and reproductive loss. Kathryn serves as the director of the healthcare programs at the Institute of Reproductive Grief Care. She is the principal author of the articles Fostering Vicarious Resilience for Prenatal Palliative Care Professionals, published in the peer-reviewed online journal Frontiers in Pediatrics in 2020, Uncovering Prolonged Grief Reactions Subsequent to a Reproductive Loss, Implications from the Primary Care Provider, Frontiers in Health Psychology in 2021. Kathryn is passionate about evidence-based medicine and would like to broaden the science of reproductive grief care. She has presented on the topics of palliative care and reproductive grief care to healthcare professionals nationally and internationally. And without further ado, I would like to welcome them to this Wayside presentation this afternoon. Thank you so much.
Thank you so much, Nicole. I really appreciate that very generous introduction. You know, our goal at the Institute of Reproductive Grief Care is to equip healthcare providers with professional development courses and practical applications to really invite anyone who has been impacted by a reproductive loss and to begin that trajectory of healing. You know, I want to honor you as I know that healthcare is very challenging, especially in these days, and every day and perhaps every hour sometimes brings new changes and situations. And I really want to help to give you some tools and strategies to maybe improve upon what you're already doing. And I'm sensitive that this is not an easy topic. It may even be difficult for some as we talk about reproductive loss. Be assured I don't have any conflicts of interest to disclose. You know, our goal is to really provide that roadmap for navigating care for those who are coping with a reproductive loss. And we want to address the prevalence of these losses and the impact on the patient and the healthcare system, as well as identify those barriers to reproductive grief care that you might have in your practice. And really, hopefully, this will help assist you in facilitating the experience of normal grieving and really to introduce those healing applications that can help you in your healthcare setting. You know, the program is evidence-based with research to support the best practices that I'll be recommending today. However, we do know that there is really a need for more research, particularly on the mental health effects of reproductive loss. And so if you or anyone you know is interested, please let me know. You know, during this presentation, I'm going to be using the phrase reproductive loss to describe a loss that occurs after miscarriage, stillbirth, abortion, early infant death, and infertility. And you know, it does encompass children who are born premature with disabilities. I know in those situations the child has not perished, but it can be normal to grieve the loss of limbs, health, or mental capacity. So I wanted to start us off with a poll. Now you can answer in the Q&A since the chat box not working, but we'll just kind of get an idea. What prompts you to assess a patient's reaction to a reproductive loss for complicated or prolonged grief reactions? So number one, the patient's made an appointment to talk about it. Number two, the patient mentions it during the appointment. Number three, when a reproductive loss is noted in the history of of the present illness or a review of system questions, or the issue has never come up. Now you can go ahead and just answer that, but I'm going to go ahead and go on just for time's sake. And I'll go ahead and send that over to Dr. Rubal.
Thank you, Kathryn. So we always like to present this in a clinical way because this is what we're doing every single day. And unfortunately, the situation and scenario is not uncommon for us. And so here we have a patient, case H. She is a 32-year-old G4P0 elective abortus 3 with 1 surgical abortion at 10 weeks, estimated gestational age, and 2 prior medical abortions. She is here for gestational age documentation with an unknown last menstrual period and a history of irregular cycles in the past. So she was seen about a week and a half prior at about 10 weeks, and the in-office ultrasound showed a crown rump length that was dating her as such, but unfortunately the exact measurements were not available. Again, we presume it's around 31 millimeters with a fetal heart rate at that time of 171 beats per minute. Her history is significant for prior heroin use, though she had been in remission since 2013. She had a methadone taper that was completed 3 years ago. She also has hepatitis C in remission after antivirals and had also quit smoking. So really had done such great work amongst all these medical issues. And so on the next slide, you can see that her medications consist of prenatal vitamins, She has an unknown family history and was married to the father of the baby for the past 4 years. She does have an overall unremarkable review of systems. And on ultrasound, we note that the crown rump length is now 32 millimeters. And unfortunately, there is no cardiac motion noted on this scan today, nor is there any movement. And so the diagnosis is made as what is called a missed abortion. And at that time, there are multiple options reviewed with the patient in terms of next steps in management, and namely expectant management, medical with misoprostol, or a surgical approach with the DNC. As you can see, many are impacted by reproductive loss. And so a 2015 study revealed that most people think that miscarriage happens in 5% or less of pregnancies. So you can understand why it's often perceived as rare and insignificant. But as we all know, it is not that rare. It occurs in about 25% of pregnancies. And frankly, it can be devastating. 1 in 160 pregnancies ends in stillbirth, and as many as 1 in 8 couples experience infertility. As you can see, there are about 20,000 infant adoptions each year in the US. And it's usually celebrated, but there are often inherent losses associated with that process, particularly for the birth parents who have had to relinquish their baby, but as well for many adopting couples who have suffered infertility and experienced reproductive loss themselves. Here you can see that miscarriage and abortion account for about 2 million losses per year, and a quarter of women of reproductive age will have an abortion. Reproductive loss surrounds us, and yet we don't talk about it. Many people express feeling isolated and alone. We find that shame and secrecy are associated with all types of reproductive loss: abortion, miscarriage, stillbirth, and infertility. So we don't equate miscarriage and abortion. We recognize that these losses occur differently, but research shows that actually the grieving and healing processes are similar. Sometimes there may not be grief experienced with an abortion. And we want to acknowledge that every experience is unique. We don't want to make assumptions as to how people are coping or make judgments as to their reactions to that loss.
All right, well, thank you so much. I'm going to go ahead and share a story written by a woman who shared her miscarriage story on one of our digital websites, miscarriagehurts.com. She tried to cope with an early miscarriage. And all the stories that are posted are anonymously written, and the writer chose to post it publicly. I'm going to read part of the story now and then kind of weave it in through the rest of the presentation, but I feel that it is a really good example of how people are affected by miscarriage. My name is H, and on January 20, 2020, I found out that I was 3 weeks pregnant. My heart swelled with love for this tiny little person. A little backstory about me. I was an addict from age 13 to 19. I put my body through hell, and I never thought I'd be able to have a baby. A few years ago, I met my husband through a mutual friend when we started working together at the same construction company. Now, finding out about the pregnancy, we had figured out that the conception date was right around Christmas. In the following weeks, we told a few family members. Everyone was happy for us. I thought it was time for my life to finally get better. I was diligently reading books, forums, blog about how to take care of myself and this new baby inside me. My doctor did an ultrasound and we heard the baby's heartbeat. The baby was very active. It was magical to see. On March 13th, I went back to the clinic for the scan. The technician was kind of a jerk, but I was too excited to see my baby again that I didn't even care. This is where the heartbreak began. This doctor barely looked at the baby. Maybe for 15 seconds he had the wand on my stomach. His phone was ringing off the hook since the second I walked in. He left the room to check his phone and then came back in with the office phone in his hand, and he said, "It's for you." So I took the phone and Another doctor from a completely different clinic told me verbatim, "Hi H, this is Dr. D. Unfortunately, there's no heartbeat, so it's a failed pregnancy. We're going to have you come in for an emergency appointment on Monday with your regular doctor, okay?" Okay, thanks, bye. Word for word. I was shocked. I was broken. I didn't know what to do. I saw the heartbeat 11 days before this. I wasn't cramping or bleeding. I was still sick in the mornings. My superhero sense of smell was still there. My breast still hurt. I still felt pregnant. Sorry, having trouble with the. Intuitively, it can be difficult for us to see how one would grieve a perinatal loss in comparison to the loss of an adult or an older child. But there are simple things that we can do to minimize disenfranchised grief. So Dr. Doka is a leading expert on grief counseling and therapy, and he found that he coined the term disenfranchised grief to describe a loss that's not openly acknowledged, it's not publicly mourned or socially supported. And he found that, society inhibits grief by establishing grieving norms that deny grief to persons deemed to have insignificant losses or insignificant relationships, such as the death of an ex-spouse or an unborn baby. It might be easy to believe that people don't share abortion stories because of the stigma or social or political fears, but what might be surprising to you is people don't talk about miscarriage or infertility stories either. And one study revealed that almost half of the people who have experienced miscarriage or whose partner has feel guilty, and a quarter of those feel shame. So I wanted to read you an article from Lang and her colleagues, and she said that among healthcare professionals and society at large, perinatal loss is generally viewed as a less traumatic or prolonged experience than the death of an older child or an adult. Perinatal loss has been characterized as an ambiguous loss, stemming from the concurrent physical absence of and psychological presence of ambiguity, has the potential to be further compounded by the disenfranchisement of the parent's grief. Many people find it hard intuitively to understand why the grief for a child who has not lived long enough to define him or herself should be so prolonged or intense. Bereaved parents often find it hard to reconcile their intense feelings with society's lack of validation. Secrecy or shame can lead to the disenfranchised grief. Again, it's a grief that's not culturally acknowledged. It's often treated like a non event, and the individual doesn't feel like they're entitled to grieve. Reproductive loss is prevalent, and we know that everyone reacts differently. And there is a body of research using the perinatal grief scale to measure that grief. And not surprisingly, the researchers found that there was this large range of emotions and no set time or way how people react. For many grief reactions, they found that included difficulty coping, despair, and depression, which can linger for a year or more, or even decades for some. The researchers had an original assumption that partners would be impacted less by reproductive loss, and that was found to be untrue. The scores indicated that although the one carrying the pregnancy's grief was more intense immediately following the loss, the partner's grief tended to be delayed. So at 24 months, they were scoring higher, particularly in the subset of despair with feelings of worthlessness and hopelessness. It's in reality, it's not really a bad thing for partners to spread apart their grief. So one person grieves while the other is providing the care, and that can reverse or flip. But we find that it doesn't really tend to happen that way, and it tends to be a bit one-sided. And we find that the partner's grief never really gets addressed. So I wanted to continue with H's story, and she said, so the following Monday, my husband and I went to my regular doctor where she confirmed that my baby was dead. She took one last picture for me to keep. The feelings of sadness were almost matched by my feelings of disgust. My body failed me. My body failed my baby. There was a dead thing inside me, but it was my baby. But it's dead, but it's mine. The guilt and the shame and the fear and the general horror set in. I felt insane. I still do. My doctors and I discuss the options, take pills, wait a couple of weeks, see if my body does what it's supposed to do, or have a DNC. I knew I wouldn't be able to handle it on my own. I wouldn't be able to miscarry at home. I would go insane having to see my baby. I would have gone crazy. I had a consult with a doctor who was able to schedule me for March 23rd for the procedure. She made it clear that I was far enough along that I could have run the risk of serious complications if I tried to do this at home. For the first time, it felt like someone understood, even if for medical reasons only. Today is March 26th. I'm at home on bed rest. I'm still bleeding. My stomach is flat. My breasts feel normal. I'm not sick. I don't feel my baby anymore. I feel so angry. This isn't fair. I did everything right. I was ready, willing, and able to be a mother. I know beyond a shadow of a doubt I would have given my life for my baby. I never held her, but I carried her. You know, sometimes people ask, how can we grieve someone we've never met? So Jackie and Diamond are psychologists in the Center for Reproductive Psychology in San Diego and recognized specialists in reproductive counseling. And they first began to define and describe reproductive story. You know, we all have a reproductive story that really we begin to write very early in life. So as children, we're watching our parents, playing with our siblings, you know, playing with dolls and cars, and really thinking of that family of our own. It's not really sophisticated at first, and it changes a lot over time. It can start with, you know, little things like, yeah, I want to have 2 girls and 1 boy, or I'm going to have all boys. You know, I'm not going to make my kids eat vegetable when I'm a parent, or I'm going to let them stay out late. But it really evolves into our story, how our family will look and how many children we're going to have. And we all form this picture or image of what we think it will be like. And then all of a sudden that can change with a reproductive loss. It can be devastating. You haven't just lost your child, you lost your hopes and dreams for yourselves and your family. So you can see from this how that bonding begins before conception. And the intensity of the grief is not necessarily related to the length of the pregnancy, rather to the hopes and dreams that one had for that pregnancy. And one element that we never write into our reproductive story is the loss of a child. And when that loss occurs, a person has to essentially rewrite their story. You know, Jackie and Diamond found that everyone grieves differently and at their own pace, and they also found 3 fairly consistent themes among those grieving a reproductive loss. They found that not only has a child died, but part of themselves has died as well. There's a loss of hopes and dreams for themselves and their child, and really feelings of failure at the most basic level. And everyone assumes that they can have children on demand. They're really completely unprepared when that doesn't happen. And there could be, you know, with any type of reproductive loss, there's feelings of failure at the most basic level. So we find that people will say, my body betrayed me, I'm a failure, I cannot carry a baby. And we heard that from our exemplar story H2. Some may question the feeling of failure with abortion, but many will say that they sense that they failed because they weren't able to welcome or care for that child when they found that they were pregnant. There's also multiple layers of grief and really losses on many different levels. So imagine the feelings after having multiple miscarriages or a miscarriage after an abortion. You know, your interaction and attention to that grief can potentially mitigate these detrimental repercussions. So we find that disenfranchised grief or the inability to express grief can sometimes have an impact on one's mental health, sometimes not. We shouldn't assume that anyone has a difficult or negative reaction to their loss, but it doesn't mean that it's a non-event. And we really want to make sure that we're understanding that everyone's impacted differently and their experience is unique. And, you know, we also find that someone's reaction can intensify or change over time. So if someone's hurting and not being allowed to express that grief or pain, it can have they can result in maladaptive behaviors or reactions like anxiety, depression, substance use disorder, eating disorder, or complicated grief. And we find that if that behavior is long-term or constant, it can have a severe impact. Now, just to expand this a little further, we find that unresolved or grief can impact the healthcare system, and the Grief Recovery Institute in 2017 estimated that the annual cost of grief to the workplace is close to 100 billion. According to the American Psychological Association, the annual cost of depression, 210 billion. Now that was about 10 years ago, but they found that depression can lead to higher healthcare utilization, higher costs, increased morbidity. And a 2018 study linked depression to an increased heart rate, a rate of heart disease, inflammatory and autoimmune diseases like diabetes, arthritis, headaches, insomnia, and chronic pain. We also know that substance use disorder, that impact can be huge, and result in just a huge amount, 740 due to economic costs, lost productivity, and healthcare expenses. And eating disorders can have a higher risk for premature death, and recovery rates can be prolonged. You know, these studies are inclusive of all grief reactions, not just reproductive loss, but we really want to be able to mitigate that as much as possible. So I wanted to share with you what something, kind of an approach that we can take. You may remember Dr. Kubler-Ross back in the 1980s, who put grief therapy on the map with the stages of grief: denial, anger, bargaining, depression, acceptance. And she was really intended to describe that journey that individuals who are coping with a terminal diagnosis go through and their situation. So she didn't mean for these stages to be something that you went step by step as you were grieving, and it wasn't meant to describe all types of losses. Dr. William Warren, a world-renowned psychologist specializing in grief therapy, found that rather than specific stages of grief, he found that there's actually tasks to be worked on throughout that grieving process. So this is for someone who's experienced a loss, and you don't have to move in that particular order. You can actually move in and out of these different tasks as you're grieving. He found that there's not this linear process. I think a lot of people were thinking after Kubler-Ross had written what she wrote. What she didn't mean was necessarily a linear process that was step by step. And he found there's no specific endpoint. It actually is described as more of a messy experience without any official closing or end. There can be good days and bad days. You don't fix the door on it. There's no point of resolution. And you might always carry a piece of that loss with you. And there may even be trigger dates like holidays or anniversaries. So one of the first steps is accepting the loss. So a person needs to accept the reality and come to terms with the full impact which that loss may include in relationship change, maybe a change in relationship, a change in a relationship between spouses, parents, God, lifestyle, roles, or dreams. Processing that pain. So also William Warren acknowledged that each person and each loss will mean working through a different range of emotions: sadness, fear, guilt, shame, relief, and many others. So a person needs to acknowledge and work through those feelings and really begin to understand and work through them. And we find that that danger is when there's some avoiding, which can lead to the unhealthy behaviors. Also, there's this adjusting of the world without the deceased. You need to adjust and create that new future, that new you. What does your world look like without that person or that child? You can't go back to the way it was before. So it's that process of adjustment. Finding that enduring connection to the one who has died. Really allowing for thoughts and memories. Sometimes that can be pleasurable, experiencing about shared memories, memorializing that loss. And really, we find that this is so difficult with the ambiguous nature of reproductive loss. And we find that most people will say that they feel their only connection is pain or guilt. We find that people will tenaciously hang on to that guilt or that pain because they're afraid that their child will be forgotten. Really, that's why it's so important to facilitate memorializing early on. So I'm going to go ahead and finish H's story. She said, I made a scrapbook at the beginning to keep ultrasounds, little items of memorabilia to show my child when they grew up. But now it's a memorial. I don't know how to put into words how hurt I am. I feel empty. I feel lost. I don't know why this happened, and I'm so angry. I wanted so badly to have this. My husband wanted this. The hardest part is watching him grieve. He doesn't know what to do, and neither do I. Putting these words out here somehow makes it more real but less painful. I suffered a miscarriage at 11 and a half weeks. I want anyone else going through this to know that you're not alone. I want to say that everything will be okay again someday, but I can't imagine how. Thank you for letting me share my story. So I'm going to introduce another poll question. What statement would be most likely help H to accept the reality of the loss? So you can put that in the chat box since that's functional. Miscarriages are common, occurring in up 25% of pregnancies. Number 2, my heart goes out to you. I'm so sorry that you lost your baby. Number 3, it wasn't a baby since you were only in the first trimester. You can always try again. Or number 4, it's the body's way of recognizing and handling an abnormal genetic malformation. So I'll let you go ahead and answer that, and I'm just going to go ahead and move on for the sake of time. We know that your role is critical and you may have limited time. So what are simple things that you can do that don't take really extra time but can make a big difference? So first of all, acknowledge the loss. It goes such a long way in undoing that disenfranchised nature of grief. Make that intentional effort to be present and really listen during the limited time that you might have. And really, it's important to note that everyone grieves differently, even within that same family or partner relationship. Sometimes it can be hard not to judge, criticize, or wonder if others are grieving or at all. There's really no right or wrong way to grieve. It's that process of adaptation. It's a journey. There's no timelines, again, no shoulds. And letting them know this really helps. Some simple things that we would say for other types of losses are really completely appropriate for reproductive loss. So saying things like, I'm so sorry for your loss. I'm so sorry you're going through this. You're not alone. Or telling them that misreactions are okay, like it's okay to cry or feel numb. And this really helps to normalize their grief and let them know that their experience, everyone's experience is different and they have a unique experience. Don't minimize a couple or person's reaction and try and treat that couple and each person in that relationship with dignity. Try and validate their feelings individually. Tell them that, you might want to give their own family members ways to help support them. By letting them know all this, we're acknowledging their loss and giving them that permission to grieve. Also offering them those handouts and grief information sheets and resources is also very helpful. So I'm going to pass this back to Dr. Rubal.
Yeah, thank you. And then if we can go to okay, thank you. So we've all been there. You're doing a typical scan, the couple's ecstatic, but you realize that there's been a loss. I used to feel a little panicked because I didn't ever want to say the wrong thing. And when I'm nervous, I know I can default into medicalese jargon that may confuse or even make that patient offended. In fact, participants in a study by grief expert Dr. Brand regarding early pregnancy loss and provider interactions said that they wanted the providers to be empathetic, allow for the opportunity to process the information, and actively check that they were understanding what they were told. They also indicated that thoughtful use of language was paramount to the interaction. For instance, they preferred the word baby to be used when they were being told about the miscarriage, but preferred technical yet gentle descriptions when being informed about, for example, the D&C procedure. We've already reviewed how common reproductive loss is. And my practice is comprised of a large amount of fertility and recurrent miscarriage patients. So unfortunately, I deal with this loss pretty commonly. So how has my practice changed and how do I approach the initial obstetric scan now? I always start by explaining what I expect to see and either drawing it out or having a typical ultrasound photo as a visual way to acknowledge this. For example, at estimated gestational age 5.5 weeks, what I expect at 6.5 weeks, et cetera. And I always go through those specifics verbally, depending on that patient's desire to dig into that. I then ask if the patient has a preference in what she or they, if the partner's also present, would like me to call the pregnancy. So for example, embryo, baby, fetus, pregnancy. I also preface any silence before starting by saying, I may be silent for a few moments, but this doesn't mean anything bad, but rather that I'm concentrating on trying to see everything well. I do usually try to talk as much as I can throughout the scan. However, because I find that people automatically assume the worst when I become quiet. And if I see something that is suggestive or diagnostic of a reproductive loss, I do state that I'm having difficulty in visualization. Once I've confirmed loss of a heartbeat, I hold the probe still, I stop, I look the patient in the eye, and I let them know this, and I let them know how sorry I am that this is the case. I then state that I'm going to take a few more measurements if needed, plus once more confirm my findings from every possible angle, and then we can go through everything in detail. I ask also if they'd like for me to show them specifically what I am seeing before I end the scan. After ending the scan, I sit down, and again, it's so important just to explicitly state, how sorry I am. I then inquire if they would like a moment or more, or if they would like to ask any questions immediately. And of course, I also let them know I'm open to talking about next steps if and when they're interested and ready to do so. And I always give them the option for a repeat scan as well, okay? So you can see here that a model commonly used for communicating unexpected or unfavorable diagnoses is this Spikes mnemonic. And it is comprised of the following mnemonic. S stands for setup. And so these are kind of the background distraction minimization. So ensure privacy, we silence our pagers and phones and really try to create that adequate time to be able to have that discussion. We want all the necessary participants in attendance as well. Interestingly, studies support that nonverbal physical cues, so sitting down and maintaining eye contact, are more effective at increasing trust than what we're even saying. The P in this model is perception of the patient. So I very commonly will ask, do you understand what I just explained, or does this make sense? Just to continue checking in at each point. I is an invitation to confirm that they are ready to discuss this in detail and to assess their current knowledge. Many times, like I said, I will give the patient and the partner a moment, some time to process and grieve together before we reconvene. K stands for knowledge. So we want to give the information, the diagnosis, the prognosis. And in doing so, we want to do it in plain language without the medical jargon as much as possible. Typically, I make sure to mention the following 3 points. Number 1, this is not their fault. And there is absolutely nothing that they did or didn't do to cause this loss. Number 2, the number 1 question that people have is why? I review the most common reasons very briefly at that time. And then number 3 is what will happen with the next pregnancy? For most women, even those with multiple prior miscarriages, the data support that their next pregnancy will be a live birth. I always mention that we will perform a very thorough evaluation of potential causes once we've addressed the immediate sequelae of this loss. E in this mnemonic stands for empathetic response to their emotions, allowing time to take it in or to process them. So I always am really careful to respond to the cues from the patients that they do need more time to process what we're saying. So examples of this include crying or repeating the diagnosis, appearing to be in shock or numb. And if I notice that, I do preface it by saying that I can give them another moment so they don't think that I'm just staring at them or waiting on them to compose themselves, for example. And I'm going to review some more aspects of the empathetic response on the next slide. But the S in this mnemonic stands for strategy and summary of the plan for moving forward. So we're going to provide those options. We're trying to balance our preferences as providers for that patient's needs and preferences, we want to consider those emotional needs as well in this vulnerable situation. Of note, the finding of Dr. Brand's study revealed that the descriptions of the miscarriage and the review of the D&C procedure were frequently cited as a source of stress. The researchers recommended trying to avoid saying missed or spontaneous abortion, scrape, suction, removal of the baby, removal of contents, or removal of parts. It made them visualize the body being dismembered. Also, if possible, please try to avoid saying that the body will take care of itself. And in that study, what they found was that the women felt like it was hurtful to hear, since they were feeling some self-blame already, that their body was unable to support the pregnancy and the baby in this situation. Please make sure that the patient understands what you said gently by asking the patient to explain back what was told. So, for example, a good question to do so is, can you tell me what I've just said to you, instead of just asking, do you understand? So we use the mnemonic nurse in order to show the empathetic language that we can follow, okay? And so N is naming or stating that emotion. U is understanding and legitimizing their reaction. So again, the women in the study recommended avoiding statements like, it's common. They felt it trivialized their loss. Respecting and praising the strengths of the patient and the partner in the situation is also important. Conveying support, of course, is also critical. And then, of course, exploring or asking the patient to elaborate on any emotions that they share is also helpful. So this is another poll question in terms of our response as we're describing our management options. And so how can you gently describe the next steps? Number one, we can opt to do nothing and hopefully the body will take care of itself. Number two, a tube will be inserted into the uterus to suction out the remaining fetal parts. Number three, we will use surgical instruments to help pass the miscarriage tissues and restore the surface and function of the uterus. Or number four, medication can be administered that will induce uterine contractions, which will expel the remaining fetal contents. And again, just as before, if please feel free to put your answers in to the chat. And in the interest of time, however, we will continue to moving on. But I think it's always important as well is to consider ahead of time how you would have that discussion about a miscarriage and the next steps.
Thank you so much. It's also important really to ask the patient and their families about their preferred cultural and spiritual practices, rituals, or customs that they would like to have honored. For instance, some cultures do not name an unborn baby or stillborn baby, while other cultures may have particular recommendations for caring for bodily remains. You may also want to consider how that patient and that family makes decisions. So we find in some cultural groups, there may be a family member that acts as a spokesperson, which may or may not be the patient or their partner for that particular family unit. So you want to find out that information. Gender roles might be more pronounced in some cultures. Some partner relationships or cultural groups may already experience or have a perceived level of disenfranchisement from the society or the healthcare system. So they might experience a dual disenfranchisement of that grief. An immigrant may or may not share their parents' homeland values, and so their grief response may look completely different from what their parents may display, or maybe totally different from another patient that you may have helped in the past. Research indicates that religious and spiritual beliefs really support and promote better coping for individuals who have experienced a reproductive loss. It's also important to note here that there really is an increasing number of patients who are not going to identify with any religion or particular spirituality, but it's also important to understand that they will still grieve and have particular ideas about memorializing and making sense of their loss. So I generally try and find them a chaplain, either the hospice or hospital, that can really help them make sense of that loss. Also, regardless of one's cultural, religious beliefs, an unexpected pregnancy loss is a devastating experience for anyone going through that. It's also really important to ensure safe and dignified handling of the physical form of the baby's body in accordance to the express wishes of the patient or that family. And we really want to discuss those options per hospital facility and state regulated policies. I'm just using California for example. At 20 weeks, the loss is considered a stillbirth, and a death certificate and disposition options have to be provided by the hospital. But prior to 20 weeks, there really aren't specific guidelines. A gestational letter is required by a mortuary or funeral memorial park prior to handling the physical form of the baby's body for burial, cremation, or organ donations. And different states have different regulations and policies. At any gestation is really proactive in reassuring the patient that the physical form of the baby's body was treated in a dignified manner. We want to provide that family with funeral burial options if they're desiring that. And really not knowing the disposition of bodily remains can be a source of anguish and a haunting experience for many of those experiencing perinatal loss. Others may not wish to have any contact or knowledge of what happened to the physical form of the baby's body, and those decisions really need to be honored as well, and really help to support them in whatever decision they're making. So we know that H in that story did not want to know. That would have been a real source of trauma for her. So also give them that resource list, digital and printed resources. Think about referrals to multidisciplinary professionals, the chaplain, a social worker. If you're an outlying clinic, you might want to be introduced to the hospice social worker and chaplain, or hospital social worker and chaplain, and maybe they can be a resource for you. Sometimes there's barriers as to why we don't provide this type of active grief care. And so I think the QA box is enabled. So what is the most challenging barrier to the provision of reproductive grief care in your practice setting? Maybe it's lack of resources. You don't have that multidisciplinary support. You don't have digital printed resources or support groups available. Maybe number two, not enough time. I find that that's always for me. Also, maybe your own personal history of loss, or it feels uncomfortable addressing the grief. Maybe you're afraid that you'll say something that will worsen the anguish. Just kind of for note, this was something that was presented at a large Midwest training hospital, and a quarter of those said that it was their own personal grief history or fear of saying the wrong thing that were barriers to them providing that grief care. So you can go ahead and answer that, and we're just going to go through a case study, but we only have a few minutes left. So we want to leave about a few minutes for, yes. So.
Thank you. Yes. So you can see that patient H returns to you for a 6-week follow-up, and physically she's doing well, but she reports that she's continuing to have difficulty coping with the loss, and she's still frequently missing work. How will you assess her grieving experience? What can you do to help her with acknowledging the impact of the loss? And what can you offer to her for ongoing grief care? And so we're going to recap how to assess for this patient's experience of the reproductive loss. And we'll start simply. How are you doing? Or I hope you aren't blaming yourself. And I can assure you that this isn't your fault. We want to, again, assess for cultural and spiritual values and how those might impact the patient. You may ask, are there particular cultural customs or rituals that are observed in your family after loss, or that you'd like to observe? We also remember that what can be said using gentle, empathetic language to assist her with accepting the loss and processing the pain, and perhaps starting to create an emotional connection. I can see that this is a loss for you. How can we support you? I'd like to hear how you remember your baby. Are there ways that I can support your memories, like keepsakes or ultrasound photos is one that I commonly use that patients do tell me they appreciate and keep, for example. And how might you assist her in the ongoing grieving process? So what types of resources or referrals, as we've said, that can you include for this ongoing grief support? And then of course, those referrals and resources include the chaplains, the psychologists, support groups, both locally and online, have been a wonderful help for many of my patients. We also want to remember and consider the partner's grief reaction and support. So we never want to minimize that potential grief for him, and realize that people grieve very differently and have a different need at different times potentially in their grief. So I think it's safe to say that we are all impacted in some way by reproductive loss, professionally and personally, and maybe even in our own family. It would be good to keep in mind that the grief experience from reproductive loss goes far beyond the actual encounter of a patient enduring a miscarriage or other type of loss. Consider this, perhaps a patient coming into the hospital or clinic for a different reason. For example, a UTI or pain from a ruptured ovarian cyst, that this patient, if she is displaying a disproportionate degree of distress, may be experiencing a delayed or prolonged grief reaction from this prior reproductive loss. So hopefully using the tools today can really help to change the grieving trajectory for many of these patients. Research indicates that if these patients have their grief acknowledged, enfranchised, and are provided follow-up tools, that they may begin to make sense of their losses and begin healing from this pain. Ultimately, our hope is that through your compassion and empathy, the negative impact of disenfranchised grief related to these reproductive losses can be mitigated one person at a time. Thank you.
Thank you.
Thank you both so much, Kathryn and Lauren. This was so informative, and I did ask everyone, I believe everyone, pretty much everyone is still here. If you could just hang around for maybe 5 extra minutes. I want to allow anyone who has any questions to please put the questions in the chat. I can't thank enough the Reproductive Care Organization. You have filled an amazing need that we knew needed to be filled in this maternal infant health series. And you have provided us with such valuable information. I see a couple of questions in the chat, so I'm going to move right to those. It says, the thing that affected me the most was all the profile ads. How would you address this? Excuse me, pro-life ads.
You mean on TV or, oh.
Could you share a little more? Where are you seeing these pro-life ads, propaganda? So just around in community that was harmful.
Oh, Lauren, do you have an answer for that?
I think that in terms of, just in our daily lives and really moving around and being presented with some images that can feel very traumatic and reminding us of those grief, I think that the first thing to think of is, first of all, again, you aren't alone in really experiencing this. I think that the other part, what I like to do when I'm encountering something else that feels hard to see, is just remembering perhaps that what are the intentions behind it. And I think that for a lot of us, as we're seeing some division in our everywhere, it feels like, to remember that at root, I think that everyone is coming from a place of trying to be well-intentioned. And sometimes in remembering that, it helps to kind of to heal or be able to move on from it. But I don't know in terms of specifically, Kathryn, if you have any thoughts as well about how to deal with fallout from seeing those.
Well, we have a wall of emotions on our digital websites, and the 2 most common emotions that people share, I mean, there's over 100 listed, is alone and afraid. And I think that developing that community, and we do have, using websites or finding that community can help you to not feel so alone and afraid. And I think that really helps when you're being supported by others who have gone through a similar situation. So I think that can help with that trauma and and sharing how you might have felt seeing those signs or things that were disturbing to you, and with others who are going through similar situations. So having that support will make you make it feel like you're not alone or afraid or being attacked if you're feeling surrounded with people that are supporting you.
I think I would add too, I come from a family where we know my grandmother's loss, right? And so the next generation, and I'm fourth generation, so you're talking about 3 generations that know about Donald Joseph, right? We know his name, we know he was my grandmother's son. And subsequently, it gave voice to other family members that when they experienced loss, that whether it was SIDS or otherwise, right, our family was able to embrace them. They weren't alone, right? And there was opportunities for support and understanding. And I think that, we are different. We are a nation of differences, right? That we have learned to value. And I hope that that's increasing. And just to know that everyone comes from different perspectives, and different experiences, and to find like-minded people who may understand your needs and seek that support, right? Because we can't control what others do, but we can control how we heal and address our needs, and not be afraid to go into community to be able to do that, right? Because that's where you're going to get the support. A couple of things that you said that I thought was really valuable was language. You're calling us into understanding about the power and the use of language. And I feel like it is so prevalent now that we should pay attention to that. And I thought that was really critical. And then coming from a restorative practice background, I would also, in that list that was shared about what kind of supports that might be needed, to ask them, is there a caring, supportive person that you would like to be here with you? Or should we contact them? How can we help you? And do you have support in your family? Like really right there in a restorative practice way, asking who's in your village, who do you trust, who could, like this warm handoff, right? Because it may not just be that social work referral in the building, right? Or here's an organization that cannot feel like a warm handoff, but really being very intentional if they're not there with their spouse or their partner to say, hey, who might that be? Yeah, we log a lot of different information, right, in our health records. That would be great to maybe have with their permission. So again, I've just learned so much, and I'm in this particular piece around maternal health, I am so interested in, and it's like, okay, what more can we do and what more can we share? Because I feel like, as you said, many people feel alone in this, and they're not sure where to go for that support, and to give them voice to this story. And the last thing that I would say, the one thing I've learned about maternal health is the power of storytelling. And so I'm happy to hear about the website, and that you can post and share things, and you can choose how to make it private or not. And I think that's really critical of learning how to embrace our stories and share that narrative. And I feel that that's very empowering.
Nicole, thank you, Nicole. I really agree with everything you're saying.
Thank you. I did type before I started chatting if anyone else had any other questions. There are many thank yous in the chat. Thank you. People are feeling more prepared to work with their clients around loss. Just saying thank you for sharing. I just always get really full at the end of these, because I just feel like, wow, I have new learning, right? New information and new resources. And so anyone who is on this call, I want to thank you so much today for participating in this Zoom. And please know that we have a new national partner that has all these resources on their website, and we can continue to learn and partner with them to share local resources to our clients and organization and community members. Thank you, everyone, for attending.
Thank you. Bye.
Thank you. Have a great afternoon.